Good morning, everyone. Welcome to another great day of presentations. We're really excited about the opportunities for networking and, of course, very excited about our membership banquet and induction ceremony this evening. So just a little housekeeping activity. We do have a full house for the banquet. So if you're planning on purchasing a guest ticket, you need to do that by 12 noon today, and you can do that at the registration desk. So as co-chair of the keynote speaker, I have the really unique and pleasure of introducing our next speaker, Dr. Manik, who will discuss his unique interdisciplinary approach to managing chronic pain in primary care. And let me just tell you a little bit about Dr. Chhabra. He's a primary care physician at the Corporal Michael J. Crescenz VA Medical Center in Philadelphia. He is also the medical director of the Indigo PAC, which is a clinic serving high-risk patients with chronic pain and substance use disorders. Dr. Chhabra recently completed the RWJ Clinical Scholars Fellowship at UPenn. And Dr. Chhabra's research interest is in the management of opioid use disorder in primary care and the role of health systems addressing housing inequality. Please welcome to the stage Dr. Chhabra.
So thank you so much for that introduction and for having me here today. I'm really excited to speak at an interprofessional conference about our work. So as Liz mentioned, as a brief introduction, I'm a primary care physician, and about 8 months ago I had the chance to launch and direct an interdisciplinary clinic that focuses on patients with chronic pain. So the clinic is finally up and running, and I'm excited to share with you about that today, and also a little bit about what I'm calling the chronic pain conundrum and how our team, the Indigo team, has been addressing it. So we work at the VA in Philadelphia in the main facility, and as you can imagine, a lot of our veterans have chronic pain. And so we're called Indigo Pact because, well, so at the VA in Philadelphia, all the primary care teams have different colors for names, and indigo was the only color of the rainbow that wasn't taken. So every person in this picture comes from a different profession, but we're all working together to address chronic pain in our patients, and so I'm happy to share that with you. So just as some background, no financial disclosures or any conflicts of interest. And so if we're going to spend the next hour together today, there's something that you need to know about me, and that's I'm a big This American Life fan and have been so for the past 20 years. And so, as an Ira Glass fan, this is something I've always wanted to say. Our story today in 2 acts. So I'm going to spend the first 20 minutes or so outlining what I'm calling the chronic pain conundrum and what's made it so difficult to begin to manage chronic pain patients, given their complexities, and also how the management of chronic pain is really intersected with the opioid crisis, something that I know got mentioned yesterday as well. And then with that, I'm going to mention how we're offering an interdisciplinary approach to chronic pain and how I believe that's the only way out of this conundrum and how our team is addressing that. So, Act 1, the chronic pain conundrum. So just to provide a little bit of background on chronic pain and its definition. So chronic pain is pain that lasts greater than 3 to 6 months or past really what's the normal time of normal tissue healing. And so that definition of chronic pain comes outside that of what we sometimes use for active cancer treatment or palliative care patients or those at the end of life of care. And so we know that the cost of chronic pain is quite extensive in this country. So about 50 million adults in the US are living with chronic pain at a given time, an estimated cost of $560 billion in medical care, but also notably lost productivity and disability programs. So that cost is greater than heart disease, cancer, or diabetes. And so thinking about what that healthcare burden is for patients with chronic pain, so we know that within our patient population, we have high rates of co-occurring depression, PTSD, and substance use disorders. We know that individuals, especially those with chronic pain and comorbid depression or mental health, are less likely to work, and they have very generalized pain. And in that population, we see increased primary care use, ED visits, as well as hospitalizations. And so thinking about the veteran population that we serve, we know that more than 50% of our male VA patients in primary care report chronic pain, and that prevalence is probably even higher within our female veteran population. And so for those who are returning from recent conflicts, pain is the most frequent presenting complaint of those individuals. So understanding the chronic pain conundrum really requires understanding how it's intersected with the opioid crisis. So the emergence of the opioid crisis and its intersection with chronic pain for the past 30 to 40 years has largely occurred in about 5 stages, which I'm going to go through. So that first stage, we began thinking of pain as a medical problem. And as a medical problem, we began associating with it a quality metric, and then beginning to attach reimbursement to it. And so with that increased focus on pain as a medical issue, we also began increased prescribing to manage that. And so with that became the increased prescribing of opioids. From that, the increased prescribing of opioids played a role in the emergence of the current opioid crisis as we know it today. And in that fourth stage, there's been a response in the medical community to begin thinking about how do we manage chronic pain most efficiently, and really, are opioids the right way to do it? And then 5, the fifth stage, is where we are now, which is the policy response to that crisis. So going through that, so the increased attention to pain is a measure of patient satisfaction and quality. So over time, we've begun to see that pain has become an intense focus within the healthcare system. And with the development of these quality measures for reimbursement based on quality, it's begun to elevate the importance of the treatment of pain in unintended ways. So let me take you through some of those steps. So the first was that I'm going to point to is the introduction in 1995 of pain as the 5th vital sign. So something that should be paid attention to in all hospital rooms across the country. And so that was introduced by the American Pain Society in 1995 and adapted by the Veterans Health Administration in 1999. And so the Joint Commission in 2001, soon after that, began to emphasize pain as a quantifiable measure, something that we should be looking at and measuring in every opportunity. Alongside of that, an Institute of Medicine report called for patient satisfaction as a measure of quality and a proxy for the patient experience. And so with this attention to patient satisfaction as a component of quality, in addition to sort of the elevation of chronic pain, or the measurement of pain, we saw AHRQ in their HCAP survey incorporated patient satisfaction as a proxy for quality in their surveys. And they had 3 questions related to pain. And I would argue overemphasizing pain as a metric, as a component of quality. And soon we began seeing that being attached to reimbursement. So first, the Deficit Reduction Act in 2005 required hospitals to submit results of these surveys or incur a penalty in terms of reimbursement. And then finally, there's become an expansion of the HCAP survey's role in the reimbursement to hospitals. So as we see, the policies that address pain have become important not only to how we address that single encounter in a hospital room or an exam room, but also how the entire health system has begun to amplify its importance through the creation of these quality measures and hinging reimbursement based on that. So concurrent with these changes in the attention to pain as an important issue for providers and health systems to address, we began to also see changes in pharmaceutical prescribing to address pain. And that largely stemmed out of 2 small studies that were published that weren't all that well done methodologically, but were published in prominent journals and began to have an outsized influence on the perception of opioids as non-addicting in the setting of chronic pain. So first was a letter to the New England Journal in 1980 claiming that a very small percentage of patients developed opioid use disorder while receiving opioids in the hospital. The second was a review in pain in 1986 of 38 individuals on pain medications for whom, who had chronic pain, for whom only 2 had substance use disorders. And so based on this evidence and this belief that those who have chronic pain can't really begin to develop use disorders or addiction, we began to see an increased use of opioids in chronic non-cancer pain. And so the American Pain Society developed guidelines for management of pain. And while they did talk about multimodal modalities for managing pain, they also primarily focused on pharmaceutical approaches. And so between 1990 and 1995, we saw an increase in 2 to 3 million opioid prescriptions being written yearly. And that significantly changed in 1995 when Purdue Pharma received FDA approval for OxyContin. And so a lot of their marketing for that medication was based on that early work that began to describe OxyContin as something as non-addicting. And so over time, we got to where we are today, which is in 2012, there were 259 million prescriptions written for opioids and greater than $9 billion in sales. So a dramatic increase. And so despite some of those early policy recommendations that were advocating for a multimodal approach, we saw a wide swing towards a medically focused approach, spurred both on by the focus of the pain experience as a measure of quality tied to reimbursement, and the view that opioids were non-problematic in the setting of treating chronic pain. And so when we look at the treatment of non-malignant pain in the United States between 2000 and 2010, this is in outpatient settings. We saw the number of visits that were treated with no pharmacotherapy dropped by about 12%, and those that were actually treated with opioids for individuals who are presenting to outpatient offices with pain increased by about 73%. So with that emerged the opioid crisis. And so part of that had to do with the increased supply of opioids, which the increased prescribing certainly played a role, but also what played a prominent role was the influx of cheap, high-quality heroin, as well as other illicitly manufactured synthetic opioids. So that began to increase the frequency of use, as well as problematic use. And in that setting, there actually have been very limited treatment options that were widely available in the community, a problem that still continues today. So ability to access methadone clinics was hard for a lot of patients, and there wasn't readily available medications for addiction treatment, including buprenorphine as well as naltrexone, available in primary care settings. And so we get to our overdose crisis. And so this is a graph I'm sure many of you are familiar with, looking at the overdose stats in the preceding 12 months. So in 2017, over 47,000 deaths were from opioid overdose. And so we have local and national headlines daily documenting the scale of the opioid crisis, such as this one from my hometown in Philadelphia. And so within this crisis, we began to also have a shift in medical understanding of the use of opioids for chronic pain. And so this has begun to have a profound effect of how we've begun to see chronic pain prescribing. And so new data has emerged about whether or not opioids are the best first-line therapy. And so this study is an example of that got a lot of notice because it was within a veteran population. It was a well-done randomized controlled trial taken over the course of a year that looked at opioids versus non-opioids in the management of chronic pain. And so in the study of 240 veterans, those in the non-opioid group had both decreased pain intensity and fewer side effects. So this added to sort of the understanding that maybe opioids are not the first-line therapy for our patients because of all the complications with the opioid crisis, but also really in terms of actually impacting individuals' pain. And so within that, the CDC put out guidelines in 2016. And these are really meant to simply be guidelines for providers to help them better understand how to manage chronic pain. But within those guidelines, they drew attention to a couple of numbers. And so one of those was looking at the risks of prescribing opioids over a certain morphine milliequivalent. So if people were on a dose of opioids or morphine that was above 50 morphine milliequivalents daily, and then really discourage prescribing greater than 90 morphine milliequivalents daily. So again, these were guidelines based on evidence, but were not meant to be like hard lines in the sand about what to do or what not to do. But we've begun to see in the policy response to that crisis, a lot of institutions have begun looking to do something, right? So you've got providers who are seeing this all around them. You've got communities and health systems, as well as state agencies, looking to enact policies to do something to address the overdose crisis and the opioid crisis in our cities. And so they've took those recommendations and begin to institute that into practice. And so while I understand the desire of many of these agencies to address the crisis, I'm going to argue that many of their reactions to that crisis and some of the policies they put into place have actually led to the chronic pain conundrum. And so we see that in a number of different forms. So payers have begun to implement prior authorizations for opioid prescriptions and are really highlighting the fact that with these policy changes that they're reducing the number of prescriptions that are being written yearly. We've also seen states in these Medicaid programs begin to reduce the number of opioids that it's allowing patients to have in terms of their doses. So policies have been enacted in about 15 states, including Colorado, Oregon, and Arizona. And notably in Oregon, they used those CDC guidelines to say, we're going to mandate tapering down of patients who are above 90 morphine mill equivalent. So despite what's going on with that patient, we're telling doctors that this is what's going to need to happen for the management of their care. And thankfully, that didn't pass, but this is part of the proposals that are being put forth. And so there's also been an increased focus from law enforcement on prescribers. So this was just within the last month. In Wisconsin, so U.S. attorneys issued warnings to opioid prescribers. These are nurse practitioners and pharmacists, as well as physicians, and telling them that their license would be at stake if they continued prescribing as they had been. And then finally, we now see that the NCQA, the quality measures that are being adapted, now examine quality based on the number of patients who are below a certain opioid threshold. So in effect, this is a pretty stunning reversal from 18 years earlier, where quality measures that began to help push up opioid prescribing by focusing on the medicalization and the reimbursement in medical settings are now telling those same health systems to say, no, we need to sort of back off. And so with that, the response from providers has been, why bother, right? So they've got increased scrutiny of their prescribing practices. Now they have to take more and more time to complete these prior authorizations, and they're seeing patients back to back again for reevaluating their treatment plans when they begin to take away the opioids and it's not succeeding. And there's really a lot of confusion about what the right treatment course should be. And so what I'm hearing from providers within our VA system is, I don't prescribe opioids anymore. And so with that, we begin seeing patient abandonment. Right? So patients who've been on long-term opioids as part of a system that's been promoting opioids as the sole mechanism for managing their chronic pain are now being told by providers that they're no longer going to get them. And this caused a great deal of distress. So now they're left in a lurch. And so what we're seeing with that is that as the providers decrease or stop prescribing opioids, there's suddenly an increase in suicidal ideations and attempts as a result of that. So just this week, I've had 3 patients come in where this was the case, where they were told by their providers in the community that they were no longer to get opioids. So let me just take you to through one of those individuals. So I had a 32-year-old gentleman, had been on opioids for chronic pain for about 8 years, ever since leaving the service. He was leading a very functional life. He had a family he was taking care of, he was involved in their lives, he was leading a job, and was providing for his family. But a provider in the community who'd been getting those medications from retired. He had a new provider come in, told him, I'm not going to prescribe these medications for you any longer. They're not indicated. So that provider gave him a 30-day supply and then said, good luck. And so once he ran out of those medications, he began to experience a withdrawal as a result of the dependence on that medication, which wasn't really a use disorder. It was dependence on that medication. And suddenly, all that function that he had in his life, the interaction with his family, taking care of those financial responsibilities, fell away. And he began drinking more to cope with his pain. And so he told us, they just cut me off from my opioids, and I couldn't take it. The pain has been so severe, I just feel like ending my life. And I would never do it, but I just don't know what to do anymore. And so this is a pretty common response from a lot of the patients we're seeing. And with this, with this understanding, this has become more prevalent in the press. So this was a popular Medium post from one of the physicians stating that documenting the number of suicides that were related to a forced taper. In the past month, there's been 3 articles in the New York Times looking at the balance of opioid prescribing and whether or not that actually reduces overdose risk, but really the short-term risk to patients in terms of increasing suicide rates. And so while these policies might make sense on the front end for those who are experiencing pain and reducing the number of initial prescriptions, the impact on patients whose entire medical plan for decades, who's been shaped by one method of care, has been pretty substantial. And so suddenly you have providers reacting not really out of malice, but out of misunderstanding, uncertainty, and incentives to change course. And so that's had disastrous consequences for our patients. And so while some of these policies might be reducing the overdose risk, we really are seeing that it's increasing the suicide risk. And so we find ourselves in a bit of a cave, right? It's a place of distress. There's a place of feeling lost with little light filtering in and offering a way out. And that's true for both providers as well as patients. And so this is the backdrop of what's happening in the country. And now I want to take you to what we're doing in Philadelphia. So I'm going to say that our clinic is necessary not simply because of the opioid crisis, but also because of the overcorrection to provider prescribing practices, which has left so many of these patients in a lurch, especially for those who've been dependent on opioids. So over the next 15 or 20 minutes or so, I'm going to provide some interviews I've been doing with providers in our clinic and other clinics within the VA to help better situate you on what's happening in Philadelphia. So just as a reminder, one of the reasons what we're doing in Philadelphia certainly can't be separated from the opioid crisis in our city. And Philadelphia really is a city, a large city, that's at the center of that crisis. So the overdose death rate in Philadelphia is extremely high compared to other cities per 100,000 individuals. So while other cities might be larger, the number of deaths that we're experiencing in Philadelphia is at an extremely high rate for its size. And so thinking about the experience for providers, we know that chronic pain is extraordinarily difficult to manage in this setting. So when I talk to providers, this is the experience that they relay. The single most frustrating thing about being a primary care provider is chronic pain, by far. It's extremely time-consuming, and it often feels that there are very few things that we can do. Another provider said, sometimes there's nothing that seems to work, and there's nothing that feels intervenable. Then you hit a wall. A fair number of patients, we hit a wall. Maybe 25, 30% where you just can't help them. And so part of it has to do with the lack of experience in managing chronic pain, other than with the tool that a lot of the providers have given for years, which is a prescription, right? Physicians are only receiving about 11 hours of training in managing pain in medical school. We really didn't have any training in managing chronic pain. My training in chronic pain has been learned on my own. Now the provider, you feel alone in managing these patients. And so what we see is that generally providers have responded to the opioid crisis and pain management in two ways. These are well-intentioned providers. So one, some of them have begun to continue to prescribe for those who have been stable, with fingers crossed that nothing will spiral out of control, even though it hasn't solved the problem for a lot of their patients. And while that might work for some patients, particularly those who don't have those mental health comorbidities I mentioned, it doesn't work for all of them. Then there are those who have begun to refuse to prescribe opioids altogether. And honestly, both of these are a bit problematic because none of them is addressing the root cause of what's going on for many of these patients. And so with that, and with the emerging evidence, we see a move away from a unidimensional model of care, which is focused mostly on medications and de-emphasizing the role in mitigating the pain experience, and towards a more multimodal approach. So the NIH, for instance, came out in 2016 recommending a number of different modalities for managing chronic pain. Things like acupuncture and hypnosis and Tai Chi and chiropractors, as well as the yoga, which do have an evidence base, in addition to things like cognitive behavioral therapy, which make a difference for patients. But a lot of providers do feel lost in trying to manage this. And so as we see these recommendations swing towards this multimodal approach, everyone is put in a real challenging position. So patients are coming to the doctor in pain, and as I've showed you for years, have been told that there should be something done for their pain. And the relationships with providers for decades have really been contingent on them receiving medications. And providers in this new modality of care don't really know what to do. And so what we found at the VA is that it's not just as easy as offering these services, right? So the VA, unlike a lot of other systems, has provided these other modalities of care in an integrated healthcare system. We have Tai Chi, we have yoga, we have psychotherapy available, readily available for a lot of our patients. We have well-developed pain education programs and CBT for chronic pain. And so what happens is that patients don't really know how to navigate any of that, and providers also don't really know what to do. And we hear that from providers, right? They feel stretched in this scenario. It's never been satisfying for me to hand someone a brochure about one of these programs. I don't even know that much about what's going on in these programs in order to determine, to describe what it's like. And so I'm saying to patients, here, negotiate this nebulous thing that I don't even know enough to explain myself. And so within the VA, like within other institutions, we're seeing that these patients are often being managed in silos, right? And I think the major silos, particularly for management of chronic pain, are the primary care providers, physical therapy, pain specialty, as well as addiction psychiatry. But beyond just being managed in silos, we also see a pathway of patients that's quite difficult for both them as well as the providers. And so this sort of schematic is what it would look like for patients before they came to Indigo. So they would see their primary care provider. The primary care provider, they'd be complaining of chronic pain. The primary care provider wouldn't know what to do, so they send them to physical therapy. The physical therapist would give them a round of physical therapy and then back to primary care. A couple months would pass, nothing's been solved. The primary care provider still doesn't know what to do, back to physical therapy. The physical therapist would go through a round of physical therapy and then back to primary care. So now the primary care provider says, I don't know what to do with this. I've gone through a couple rounds of physical therapy. Let's go to the pain specialty clinic. The pain specialty clinic would say, you know, I don't know if we can intervene in this situation. This seems to be more like a mental health and addiction problem. So back to primary care. So primary care then sends them to the mental health provider. The mental health provider transfers them to the addiction psychiatrist. The addiction psychiatrist sees them and says, this is a chronic pain issue. This is not a substance use disorder. So back to the primary care physician. The primary care physician says, all right, let's go back to pain specialty. Pain specialty says, look, we'll do an injection, but I don't think it's getting any better. And they'll do that injection. And these patients will feel better maybe for a couple of days, but then right back in the setting of primary care, right? This is a really frustrating experience for providers, but really for patients as well. And this goes on and on and on, because this cycle can take a year or two, and then right back to the beginning, right? And so these providers realize there's problems with the siloed care, right? So the psychologist I interviewed, they know that the primary care provider is saying, look, we've tried everything else, so now what? And so they bring psychology in at that point. And the physical therapist says to us, look, we have pretty cynical viewpoints of primary care. Again, primary care providers say, we don't know what to do, so let's send them to PT, right? We know from organizational theory about the difficulties in distributed care, right? That there's conflict is greater within these distributed teams that are not interacting. And part of that has to do with members are less familiar with each other. They don't have a shared context or norms. They don't even understand really what the other team is doing. They just know, oh, I need to send them over there. And this is further exacerbated by the fact that a lot of our interaction with these other teams happens over EMRs or email. And so there's very few personal interactions. And so in this context, providers really begin developing disdain for the other providers, right? Because they think these other providers aren't helping with what they perceive to be the core problem. But no one really understands how that problem interacts together. And that's been true at the VA. Like, you know, when I came in, you could hear it when we were talking to the different teams. Like, oh, if only addiction psychiatry would do what they need to do with these patients. Oh, if only physical therapy would really do the pain education that's needed, then we would get somewhere, right? So into that context stepped our clinic. Right? So this is the Indigo team again. And the Indigo team came about because of all of this that was going on in the VA. And it came with a 2-year grant funding from Division, which is sort of our like regional organizing office, with an institutional commitment from Philadelphia afterwards. And so the purpose of our pact is to focus on the most high-risk patients. So the patients that we take are individuals who chronic pain has been their primary concern. And that's true for a lot of these patients. Primary care providers will say to us, look, I can't get through anything else because pain is the thing I focus on at every visit. These are individuals who have typically been on long-term high-dose opioids, sometimes with benzodiazepines, which confer an additional risk. Some of them have an opioid dependence or opioid use disorder, but not all. And almost everyone has a history of mental illness. So typically, as I mentioned, the co-occurring depression, PTSD, or anxiety disorders. So they're at high risk for overdose as well as for suicide, and are typically high-need, high-use patients for all the reasons I outlined before. And so our care team is outlined here. So we have 2 primary care providers, myself as well as a nurse practitioner I work with, a behavioral psychologist, a physical therapist, a social worker, a pharmacist, a nurse care manager, and a licensed practical nurse. So a lot of resources together in a primary care setting. And so the long-term outcomes for our clinic are to see if we can decrease use, which is often sort of the metric that health systems are most interested in. So the number of ED visits and hospitalizations for their pain concerns. An improvement in pain scores, improvement in depression severity. Are we reducing the risk of suicide and overdose? And also notably, are we decreasing the burnout in primary care? So burnout has been a prominent issue, and that cycle that we described before has been a real problem for primary care providers. And so when I think about what are the key components of our practice, it kind of boils down to these three things. And so I'll go into depth a little bit more with each of these. So the first is that we have a real co-location of an interdisciplinary team. We also have team meetings that are really creating a structure for collaboration. And then third, this clinic really offers a space for experimentation as well as innovation in managing these patients with chronic pain. So first, the co-location of an interdisciplinary team. So as I mentioned, at the VA in particular, we have these different silos, right? So we have the addiction recovery unit, physical therapy, specialty pain, the mental health clinics, and primary care, which have been sort of working separately. And so our theory of the case is that, look, let's take all of these clinics that had sort of been operating independently and choose specialties out of that and create one single interdisciplinary primary care practice and bring it all together. And so I was trying to wrap my head around what this was like, and I was talking to a colleague a few months ago, and she said, you know what it's like? It's like a blueberry pie. And so I thought, yeah, that's exactly right. So stay with me for a second. So the thing with a blueberry pie is that, each of their individual components alone, it won't work, right? You can have to get a blueberry pie, you can't just have the blueberries alone. You can't just have the butter alone. You can't just have the sugar alone. You can't just have the flour alone. You need all those things together, but notably, you need them together at the same time in order to make a difference. And so that's what we do. And so our approach is to bring these different disciplines together. And honestly, what we're trying to do is actually pretty straightforward when you try to outline it on a slide, right? From a medical perspective, we're trying to assess and reduce the risk of medications, including opioids. The psychologists are trying to do an assessment and engagement in mental health care, because a lot of them haven't done that previously. The physical therapists are really doing a lot of pain education and really just looking to increase mobility, even just walking. And social work is looking to ensure social stability. But what we've seen as a team, and we look at these evidence-based practices that I mentioned before, that again, it's not as simple as putting our team together and then offering these practices. What you really know is that these patients aren't even ready to step into those practices. So they've been stagnant for years, haven't interacted with the system in many years in this kind of way, and so it requires a lot of motivational interviewing to get them from this stage to even attend one of those sessions. And so that's been, I think, one of the most interesting things for me to learn as a primary care provider stepping into this practice is that I do very, very little typical primary care things in my initial visits with these patients. A lot of what I'm doing is reflective listening and motivational interviewing, getting them ready to engage with these other practices. So let me take you through a little bit about what sort of our initial assessment looks like. So I'll go through this too also in a little bit more detail. So the patients are initially referred to Indigo. There's a joint visit that happens with both the provider, either myself or the nurse practitioner, or the psychologist or the physical therapist, all seeing the patient together. There's a team meeting about those patients. There's a return visit where the patient comes back. Sometimes that's a joint visit or an individual visit, depending on the team meeting. And a social worker is often seeing the patient at that time. And then there's a range of follow-up visits. So in looking and talking to providers about what it's like to refer to Indigo, they are pretty satisfied with sort of this ability. Some of it is like, I don't want to do this anymore, I'm just going to kick the can, right? But a lot of it really is feelings like this. The benefit is offering a one-stop shop for managing their pain. For physical therapy, behavioral health, a social worker, medical person, all working over together. And that's something that providers realize they can't offer, right? And that's really valuable. And so, as I mentioned before, these are the characteristics that we look for in the patients we're taking on, because we think that these are the most high risk and can use the resources that we can provide that might not be available in the rest of primary care. And if patients don't meet these criteria, typically we'll either see the patient for a brief consultation and provide recommendations or do some e-consults and advice for ongoing management. But for the most part, we're taking on those patients. And so the next stage is, I think, a critical piece of what we do. So this is the joint visit, and this is the initial joint visit that we have with patients. So as I mentioned, there's basically 3 fields that are together in that room. We have a 90-minute appointment with the patient altogether. And the domains that we cover in the initial appointment are, one, just an introduction to the team and what really a biopsychosocial model looks like. We take really extensive pain histories, mental health histories, substance use histories, as well as a social history. Notably, we don't really focus at all on a medical history in this visit. We do an examination of the day-to-day function of that individual. And we do something called a personal health inventory and health goals. And so I think this got mentioned yesterday, but we're really interested in the patient's story, right? And so there's been a big push at the VA to take a whole health approach to understanding these patients and understanding that for patients, we can't just look at their medical issues, but we have to look at all the components that go into their health. And really, we realize that all those components really impact their pain experience. So it's things like their sleep, their social interactions, in addition to their medications and activities. And so the questions that we'll ask at the beginning, and I don't know if you can see that real well, but we have them all take an inventory where we ask them to rate where they feel on the following scale below. So their physical well-being, their mental well-being, and I can't see what the other one, how do you live your life day to day, right? And then we really push them on these questions and why they rank them the way they are. Again, part of that sort of motivational interviewing approach. And then we ask them questions that really drive what our next steps are and help us better understanding what their goals are, right? So we ask, what do you live for? What matters to you? And why do you want to be healthy? And that's our starting point for a lot of these individuals, because for a lot of them, they just haven't been engaged in care in this way before, and it's our way to sort of generate those ideas to help move them forward. And in talking to providers who are in my clinic, this is what they say about the value of those joint visits. So joint appointments are an experiential opportunity for the patient to see the biopsychosocial model play out in front of them. So instead of just interacting with their medical provider and saying, oh, I need X, Y, and Z medication, they're now seeing that, oh, there's a psychologist here. There's a physical therapist sitting here. And that, oh, these things are a big part of managing my chronic pain. And so in those follow-up visits, as I mentioned, we'll conduct them individually or with the providers jointly. The second visit, as I mentioned, usually involves our social worker. The visits typically occur pretty quick, right? So 2 to 4 weeks after that first visit. And again, we're focused on those things that I mentioned before, their health goals, mobility, engagement with mental health at the outset. And so let's compare this to the previous model and what had existed before Indigo, right? So typically, a patient would have a 1-hour primary care appointment as an initial visit, typically a 1-hour physical therapy evaluation, typically a 1-hour mental health intake. This would typically occur over 2 to 3 months. And so while our clinic is resource intensive in some ways by bringing that all together, it's not a lot different than this approach because this also takes a lot of resources. It just spread out over a period of time. And I would argue less efficiently. And so thinking about that second part of what I think is sort of a key component of our clinic, it really is creating these structures for collaboration. And so our team really has come together finally in the last 2 months. We finished our hiring and our physical therapist came on board. And we started off by having a team retreat. And part of that has to do, it goes back to sort of this understanding of organizational culture as well as team roles. And we know that it's really important in order for a team to succeed to sort of understand individual roles in an interdisciplinary setting, the norms, and sort of what the culture of collaboration looks like. So we have to align the goals, norms, and roles. And so we spent a ton of time at the outset having those conversations. And the second thing that we do that I think is particularly effective is we have 2 team meetings during the week. One might not be different than a lot of interdisciplinary teams where we're doing just a review of those patients. The new patients we're seeing that week, the old patients, what are their care plans, and developing that jointly as a team. The second is an operations meeting where we see how does this work? Because when it gets down to this, this seems like a smooth process, but it's really different for a VA facility or any facility to begin thinking about how do we operationalize an interprofessional clinic where we're scheduling these joint appointments, right? Like it's one thing to create a schedule for a single provider, but suddenly trying to coordinate schedules with multiple providers is complicated. And that's taken a lot of time for us to figure out. These operation meetings are also a time for interdisciplinary sharing, right? So we have a journal club. That journal club is led by a different team provider each time. So we have the physical therapists sharing their literature. We have the nurses sharing their literature. We have the medicine ourselves sort of sharing our literature. And that literature looks very different, and it's really interesting to suddenly see, oh, what are you guys talking about? How can I bring that into my practice? That doesn't happen typically, and for me personally, that's been a great learning experience. And so in talking to our providers about what that team meeting experience is like, they say, I believe you can't just have one set of eyes on the patient and know everything that's wrong. And I feel like that's what happens when you have people who work independently. But in these types of scenarios, we might be in a team meeting, and I may say, this person has XYZ diagnosis. This is the treatment plan. And then someone else might say, did you realize that they don't have housing? And then I would say, okay, we need to stabilize the patient's housing and then address these other diagnoses. And I really believe that the only way to do this is within an interdisciplinary model. And so that's the advantages of this approach, as everyone in this room knows. And so third, the space for experimentation and innovation. And so this is a unique model, and so we do spend a lot of time trying to figure out new ways to better address chronic pain. And so just as an example of that, over the past year, we've been doing a pilot study. And so we're looking at a key component for patients with chronic pain is increasing mobility. And so we're looking to see, are there behavioral incentives that we can use and lessons we can learn from behavioral economics to incent increased activity? So we're doing a randomized trial within our patient population. We're enrolling our patients. And so we're using a regret lottery. This is a behavioral incentive based on the idea that loss is a great motivator for patients. We're also providing them incentives to participate in Tai Chi or yoga classes. And as part of this study, all the individuals who are enrolled get daily text message reminders about movement. They get a Fitbit tracker where we're sort of beginning to look at their activity. And we're trying to see, can a behavioral incentive or a lottery push one group of patients to move a little bit more? And so those outcomes that we're looking at, there are increases in physical activity, pain scores, quality of life. And then a secondary outcome really is there a change in medication use? So as patients become more active, are we going to decrease their opioid use overall? So just as an example of some of the work that we're doing in that setting. So is this interprofessional practice? So as I was looking over the NAP materials, one thing that I found on the website was, the highest model of interprofessional healthcare refers to a form of practice wherein healthcare professionals from different disciplines and professions make up a team that makes a unified decision about a patient's care facilitated by face-to-face meetings. And I really think that's what we're doing. So with all of that, let me sort of take you to an individual patient case. And so this is our index case. So this is the person, as our clinic was starting, was the first patient that literally everyone thought of in terms of sending to us, right? He was one of the most difficult patients that anyone encountered. So a little bit about him. So a 62-year-old gentleman has a history of chronic pain, had been on long-term opioids, a history of depression as well as hepatitis C. He had morbid obesity and was SAS post a gastric bypass in 2017. And so, as I mentioned, he was our first patient. And so when we talked to different people around our facility, people would say, oh, Mr. B, yeah, I know him well. And part of that is because we know with some of these patients who are difficult to manage, literally everyone has some experience with them. Everyone from the people who check them in, the LPNs, the healthcare professionals, the administrative staff, the chief of staff. Everyone knew this patient. So a little bit about him. So really, like a lot of our patients, had diffuse pain. So headaches, shoulder aches, backaches, lower extremity neuropathy. And so in 2017, he was weaned off his opioids prior to that gastric bypass, but then was restarted soon afterwards. And then after that period of time, he began having increased complaints of pain, more difficulty eating, nausea, vomiting, and began to request increasing doses of oxycodone, began to overuse it a little bit. And so within this context, we began to see, like with many of our patients, sort of increased specialty visits. So he had 10 visits back to GI with repeated barium swallow, EGDs, colonoscopies, multiple imaging studies. He was sent to physical therapy, had 8 visits with physical therapy. He had 5 visits to the emergency room with increased pain. And he was, throughout this time, declining any interventions with mental health or really engaging with alternative ideas of what might be going on with his pain, because what was going on was simply that he had developed an opioid use disorder due to sort of the long-term prescribing of the opioids. He began to have distrust with the medical system, right? So he had combative behavior, was threatening providers in the setting. He requested 3 different provider changes in 2 years. There's multiple complaints and visits to the patient advocate, the primary care chief, the chief of staff. And so within this context, this is similar to a lot of these patients who are using all parts of our system. He was transferred to the Indigo team. And so this was before we fully got up and running. We were just beginning to take a couple of cases in March of 2018. And so as an example, we've seen him 18 times between March of 2018 and January of 2019. And during this time, he's threatened to fire us. He's gone to the patient advocate. He's gone to the chief of staff, the chief of primary care, saying, look, I want out. Give me somebody else. And it's taken a lot of time to build trust. And so initially, I was the one who's mostly seen him because our team hadn't come together fully yet. But the interactions with him changed dramatically when our psychologist came on board. And so suddenly, I was doing these joint appointments with our behavioral psychologist, and the whole tenor of that relationship changed. And so soon after that, he went from a place where he was saying, look, I'm not an addict. I don't want to engage with this. This is not the issue, to being suddenly stable on Suboxone. So that's taken a lot of time, a lot of trust. But this is an example of who our patients are. And it's messy, right? And so when I look at sort of our long-term outcomes of our clinic, such as all this, we're not ready yet to sort of address that. We're just kind of up and running. But my reflections on sort of where we're at for now is that, one, as I mentioned, this process takes time, and our early successes look like this patient. His pain isn't gone, but he's optimistic and hopeful again, right? He's begun to develop coping strategies to manage his pain through working with our team. There is a possibility that he's going to relapse into sort of using more things again, particularly if he faces adversity, which I would argue that gastric bypass was for him. But the other real reflection is that the only way to do this is with an interdisciplinary approach. Because without sort of learning from my behavioral health psychologist about what are the ways that I could better interact with him, we wouldn't really be here today. So outside of the VA, I understand that the VA in a lot of ways is a special system because, one, we have sort of both an organizational commitment and the resources to commit to a project like this. But if I'm going to make sort of suggestion, and right now my day-to-day work is really focused on this 200-patient panel that I'm working with. But if I'm going to make some suggestions that I don't think necessarily would have the same intensive benefit, but what can be done to better manage chronic pain patients in the community, they would be as follows. So one, improve the coverage for non-medication-based strategies. So as we all know, things don't happen unless you're ready to pay for it, right? And so insurance coverage needs to improve for some of those other modalities that we spoke about earlier, not just medication approaches. The second, and actually one of those articles that I cited mentioned this as well, revise the CDC guidelines that clarify that patients should not be involuntarily tapered off opioid medications. And some patients really might warrant these high doses. So there needs to be a bit of a shift in understanding about what is the risk in these patients and who is it that we need to move down to reduce the risk and who are patients who are living stable lives that we should probably continue. And then third, increase the coverage for interdisciplinary treatment options. And so last year, Medicare began providing coverage for the collaborative care model, and I would argue that we should use that as a similar framework for our practice, for practices in the community for managing chronic pain. So with that, I just want to thank the following individuals. So this is our team, as well as other individuals at our facility, as well as others, have been really instrumental in putting our clinic together. And with that, I'm happy to take any questions. And so as a father of young kids, I have an obligatory picture of them out there. Thank you. I'll start here and then go here. Go ahead.
Something I have come across is a dual phenomenon of pain control and euphoria. They can come hand in hand, and one can be much greater than the other. To your knowledge, have there been any studies to look at the effectiveness of pain control versus the magnitude of euphoria?
When you say a magnitude of euphoria, what do you mean? Like the euphoria that may come from some of the medications we're using?
Yeah, from the opioid itself. Case in point, a few years back I was hospitalized with necrotizing fasciitis. When it came time for a dressing change between debridement surgeries, I was administered Dilaudid in preparation for the procedure. Now, Dilaudid is a lot of fun. If you ever want the feeling of levitation, that's your medication, because about 15 minutes, you're about this high off the bed. But in my case, it did nothing to dull the pain. And so given the choice between the two, the euphoria, the sense of levitation, the sense of warmth and well-being far outweighed the pain relief itself.
Yeah.
And so, the question is, have there been examinations to look at the effectiveness of pain management versus the impact of the euphoric sensation that can come with it?
Yeah, so first, sorry about your experience with necrotizing fasciitis. That's really quite painful and extreme. So I would say that, what we see in our patients is that, so for individuals who've been on opioids for a long period of time, euphoria really is not a component of what's happening. Really, the structure of their brains have changed in such a way that they've really become just dependent on these medications to function, and that, high is not sort of what's driving the continued use. And that's true for individuals with chronic pain, but a lot of individuals who have use disorders and are continuing to use things like heroin or sort of prescription opioids in a non-prescribed manner. As to whether or not that initial sort of euphoria is sort of some sort of signaling about whether or not the pain will be well controlled, I don't really know. But I would say, again, in our patient population, euphoria really isn't the issue. It really is a change and a creation of dependence on this medication to sort of function normally over time. Thanks. Hey.
Hello. Is this on? Okay. Sue Sarinsky, University of Rochester School of Nursing. Thank you for an excellent presentation.
Thanks.
I was hoping maybe you could take a couple minutes and tell us a little bit more about the regret lottery, the behavioral incentive that you were talking about.
Oh, sure. So this is a strategy that's being used in a lot of studies now, trying to look at behavioral change. And so the regret lottery simply is, this is one way of loss aversion and sort of orchestrating that within a study. So we have patients who are in our control group. They're given sort of the Fitbit trackers and some text message reminders, but they're not actually put into the lottery. And so the lottery is that we're asking our patients to meet a certain activity goal each week. So we have a 2-week phase-in where we measure how much they're actually moving at baseline. And so we put really modest goals in terms of a weekly sort of increase. So if they had walked 1,000 steps that first, on a daily basis for that first couple of weeks, we would say, can you increase that by 5%, right? And so we're looking to increase that slowly over the course of 12 weeks. We don't know if 5% is the right number or not. We just tried to choose sort of a modest goal at first. And so for those patients who meet their, all the patients at the end of the week are entered into a lottery. So there's some individuals who actually meet that goal of increasing by 5%. And so they're actually eligible for the monetary gain that comes as a result of participating in that lottery. And so they may or may not win based on the number that they're assigned. But the regret portion of that lottery is that we also enter patients who didn't complete their activity goal into the lottery and tell them what they would have won had they met their walking goals for the week. So that's one way to sort of organize that. There's another way where people are given a certain amount of money at the outset of the study, and that either sort of stays stable if they meet their goals or decreases on a weekly basis if they're not meeting the goals. So that comes that can be created in several different forms. So that's kind of a regret lottery.
Hi.
Hi.
I'm Janice Bites from Rutgers Camden. I'm right across the
Oh yeah,
Delaware.
great.
I had a question. How many of your patients, if any, are homeless vets? And the reason I ask is one of our faculty is doing a phenomenology of the lived experience of being a homeless vet. And there are a good number. I think she's got like 35 in her sample. And it's amazing to read them because I'm on her committee. I just want to hear that.
Yeah, so good question. And so, as was mentioned at the outset, housing instability has been a focus of mine, not so much at this moment in time. But within our vets, I would say there are none that are actively homeless at this moment, but a lot of them who are experiencing housing insecurity still. And so when we do those initial intakes, we do hear from patients who that they're worried about remaining in their housing in the coming months. And so that's one thing that the VA does, which is quite interesting, is that within the outpatient setting, we're one of the few health systems that are asking about whether or not there's any concern about you'll be able to remain in your housing in the next several months. I would say we've got about 250 patients enrolled. Maybe 15 to 20 are experiencing housing insecurity, a little bit less than that. I'd just say maybe a handful are sort of like coming from shelters. We just got one this week, and then there's one other I can think of off the top of my head. So it's not a huge percentage, but certainly that instability is a real issue for our patients.
Hello, I'm Beth McCauley, and I'm a speech pathologist. And you may say, well, why are you talking to me? Well, a couple of things. First of all, as someone with a husband who's dealt with chronic pain for over 20 years, and being in physician offices where they haven't even looked at him or touched him because they're dealing with documentation to get paid for that visit and nothing else happens. And as a speech pathologist who is working with many times with people post-stroke and traumatic brain injury, where my evaluation, I'm asking the same questions as PT, OT, nursing, and psych. But the system that we're dealing with for that reimbursement is still silo-based. And so even though we found wonderful examples this week, especially yours, with where that IPE really does increase patient compliance, patients' feeling of you're finally listening to me, is with the interprofessional team at the same place. How do we go about changing, like blowing up the silos and making soup or pie, so that that experience of interprofessional best practice is supported by the payee system? And then the second thing is I want you to add animal-assisted therapy to your pain clinic.
Thank you. Thanks for that question. Yeah, I think the payment models around this are extraordinarily complicated. And I think that it's a thing that is going to really delay seeing models like this really coming into care outside of the VA system. It's hard to figure out. The model that I can think of that I worked on about 2 years ago at Penn was to begin putting this collaborative care model into practice. And so Medicare is starting to be willing to reimburse for models that require multiple professionals, and beginning to pay health systems for the time it takes to coordinate that care and to have those meetings that are important for moving patients forward, especially those with chronic pain. I don't know. My guess is it's going to take a while to get out of the separate visit model, but at least reimbursing for that collaborative time could be important, so that when you're talking to those other providers or sort of reaching out or maybe setting a time to meet, that at least can be reimbursed, because it really is those face-to-face interactions that I think have driven us and have made such a change in the way we're addressing our patients' needs. And we do have therapy dogs that come around, not part of our clinic so much as just the VA has done it. So they come around every Thursday morning, I think.
Right, but I bet if you partnered a specific therapy dog with particular patients as they came to your clinic, so each time they saw the same dog, you have an increased compliance and reduction of those feelings of I'm going to fire you.
Sure,
So
sure.
just-
Yeah, thank you. Yeah, that's a good. Hi.
Good morning. I'm Gary Pisano, a speech-language pathologist as well, and from Philadelphia. So I'm familiar with some of the neighborhoods that are, maybe impacted more so than others. And I wondered, how does community and environment play into Indigo plan and your approach?
Yeah, I think that, so it's a good question. And as you know, in Philadelphia, there are certain, like when you think about the opioid crisis in particular, there's certain neighborhoods that have been largely affected within Philadelphia. I think, honestly, that really has not been something that we've been focusing that much on up front. We know that our patients are coming from sort of all over Philadelphia, but as sort of the large VA center in the region, people are also coming from outside as well. And so one thing that we're really beginning to think about is, okay, how do I provide a service to this patient who lives actually 50 miles away and is going to one of our CBOCs, which is our sort of community-based clinics? And how do we sort of provide assistance in those settings? So we're doing a lot of telehealth, and there too, I think the VA has done a pretty good job at instituting that and trying to provide support in those settings. And so that's kind of the type of community outreach we're doing right now to provide support to providers who are working in those other practices. The other thing that our physical therapist in particular is working on is looking at these alternative-based sort of strategy. So while we do have like a Tai Chi course as well as like yoga offered at our facility, it's just once a week and people would have to come in to our facility to get that. So we're partnering with some community organizations to gain access to those types of activities closer to where they live. But I would not say it's like a very specific neighborhood community-oriented approach to sort of like targeting certain areas of the city. Does that make sense? Okay. Oh, one more question. Sorry. Thank you.
Okay, so I'm a bit height challenged with this microphone, so hopefully you can hear me. I'm Kathy Chappell. I'm from the American Nurses Credentialing Center. I wondered if you could speak a little bit about mandatory education versus voluntary education in the pain management space, particularly interprofessional education or interprofessional continuing education.
Got it. So this is, from your question, pain education for providers in particular, right? Yeah, I don't know if I have a good sort of theory of the case. I do think that a lot of what's missing in our facility is that, like I mentioned, providers don't really know what to do because they haven't had that education previously. And so in that example, like there's a bevy of resources in terms of things that they can refer to for pain education, but they don't really know what that looks like. And honestly, as a primary care provider coming new to this, like my experience had been primarily in managing like substance use disorders, but not chronic pain. And I've had to learn a ton over this past year, and that's been really valuable for me. I do think that it's necessary. I think like with any mandatory training, like how effective it is has a lot to do with how it's sold, what's the institutional commitment to it, what's the time that's provided to it, what's the quality of that training. But I do think it's needed, and a lot of the providers do want it. Do I have to complete now? Okay. All right. Thank you. I'm happy to chat with you afterwards.
Wow, that was a fabulous presentation. Thank you. He certainly challenged us to rethink about the care of patient with chronic pain. So our concurrent sessions will begin at 10:45. Option 1 will be here in this room, and 2 will be downstairs in the diplomat room. And please use the next 45 minutes to go to the posters,